Swayam Prabha. Digital India. Educated India.
Welcome to this session. In today's lecture, we are going to learn about the clinical manifestations of renal disease. In this session, I am going to teach you the various manifestations or syndromes, then differentiating clinical features, a little bit about the significant laboratory findings and the different causes for each syndrome. Now, this is the normal glomerulus. The structure of it is a little complicated and complex, but we need to understand the basic organelles as well as the cells constituting the glomerulus to understand the various syndromes. So, now in this the various capillary loops are lined by fenestrated endothelium, and in between the capillary loops you have the mesangium with the mesangial cells. The capillary loops are abutted by your foot processes of the visceral epithelium, and then the Bowman space is lined by the parietal epithelium. So, that is the Bowman's capsule that forms it, and between the parietal epithelium and the visceral epithelium lies the Bowman space, also known as the urinary space. So, this is how it looks under the microscope. This is a special stain, the periodic acid Schiff stain, also known as PAS stain, and this is the electron microscopic picture of the same, and this is the filtration unit that is comprising the inner endothelium that is fenestrated, then the glomerular basement membrane which has a lamina rara interna, lamina rara externa and the lamina densa, and abutted by the various foot processes which you see here comprising the components of the visceral epithelial cell. Now, besides that you also have the tubular interstitial component. Now, remember that the stroma in the kidney is known as the interstitium. So, tubular interstitial compartment is one, then the vascular compartment is the other one. So, whenever we do studies on the kidney, we have a look at the various compartments, but please do remember that it is interconnected and a disease of one may affect the other compartments also. So, the major manifestations are certain distinct syndromes or symptomatology comprising various biochemical abnormalities, and these include the nephrotic syndrome, the nephritic syndrome, asymptomatic proteinuria and hematuria, rapidly progressive glomerulonephritis, acute kidney injury earlier known as acute renal failure, and chronic kidney disease previously called as chronic renal failure. So, we will look at all of these, but before that we have to understand certain basics, and these are azotemia and uremia. So, what is azotemia? Azotemia is nothing but an increased blood urea nitrogen and serum creatinine, mostly because the glomerular filtration rate has reduced. Now, these are due to different causes, but it is typical and classical of both acute kidney injury as well as chronic kidney disease, but can be seen in some cases of nephritic syndrome also. It has renal and extrarenal causes. So, the types are pre-renal, mostly vascular in nature, and that could be due to hypoperfusion, that is hypotension as well as excessive fluid loss, or decreased intravascular volume as you see in shock, then congestive cardiac failure, cirrhosis, etc. Renal causes are several. The most important of these is when it proceeds directly to acute kidney injury. For example, in say acute tubular interstitial nephritis it could be, or it could be even acute tubular injury, and other some glomerular causes also like rapidly progressive glomerulonephritis when there are crescents. Then post renal is mainly because of distal renal obstruction. This could be due to nephrolithiasis, or it could be due to tumors if there is obstruction beyond the kidney. So, these are the cause of azotemia. So, how do we diagnose azotemia? Now, diagnosis of azotemia is done by looking at the blood urea nitrogen, which should exceed 21 milligrams per deciliter, then your fractional excretion of sodium, fractional excretion of urea, then your urine analysis and your urea osmolality. So, when we look at that in pre-renal, your one creatinine ratio will be more than 20:1, FeNAs less than 1, then your FeUR is less than 35%, urine osmolality is 500 milliosmoles per kilogram. Then when you check the urine, you will get only hyaline Cas. In renal, the blood urea nitrogen creatinine ratio is less than 20:1, FeNAs greater than 2, FeUR is greater than 50%, UO is less than 300 milliosmoles per kilogram. Then urine analysis, you see nephritic Cas, which we will be seeing later. I will be describing in detail about nephritic Cas, eosinophils and proteinuria. In post-renal azotemia, most of the findings are similar to renal azotemia, except that in urine analysis you will see WBC Cas, and imaging findings are very helpful here to detect the tumor and its exact location, whether it is in ureter or in urethra or bladder. What is uremia? I had told you earlier that azotemia and uremia are two important aspects we should know before we proceed to the other syndromes. Now, uremia is azotemia with clinical signs and symptoms due to various biochemical abnormalities. So, some of the important ones are uremic gastroenteritis, then peripheral neuropathy, uremic pericarditis, and it is usually seen in chronic kidney disease, and the alterations could be renal, biochemical and endocrine, various combinations of the three. So, now what happens in the kidney in cases involving the glomerulus? So, if there is proteinuria, it is mainly because of loss of food processes and abnormal filtration. So, it progresses from asymptomatic proteinuria to the nephrotic syndrome as there is an increase in the amount of your protein excreted in the urine. Similarly, if there is proteinuria along with hematuria and oliguria and the proteinuria is mild, initially it starts with asymptomatic hematuria, progresses to nephritic syndrome, then you get rapidly progressive glomerulonephritis as a part of acute kidney injury or some other causes of acute kidney injury. If it is a glomerular cause that is responsible for this progress, then it is usually seen to be associated with proliferative changes in the glomeruli, that is involving all mesangial, endothelial as well as epithelial cells. Now, epithelial cells sometimes especially when it progresses to acute kidney injury, you get this, otherwise it is usually restricted to mesangial as well as your endothelial proliferation and WBC infiltration. So, first thing is asymptomatic proteinuria and hematuria. In glomerular hematuria, microscopic hematuria is thought to be significant if associated with greater than 2+ proteinuria by dipstick method, and in this we see more than 3 RBCs per hyperfield of midstream urine which has been centrifuged. In the sediment you will see this along with dysmorphic RBCs when we look at the microscopic picture. Okay. Subnephrotic, usually mild proteinuria is difficult to detect, but remember that the normal urinary protein excretion is less than 150 milligram in 24 hours. So, anything more than that, if by chance the urine is analyzed, then we may be able to detect, and normal mean albumin excretion rate or AER is 5 to 10 milligrams per day. So, an AER of more than 30 milligram per day is thought to be abnormal. Examples or causes of asymptomatic proteinuria and hematuria include thin basement membrane disease, Alport syndrome, early IgA nephropathy. Later IgA nephropathies will usually present as nephritic syndrome. Then recovery from post-infectious glomerulonephritis, early lupus nephritis and Henoch-Schönlein purpura. In all these cases, microscopic examination in light microscopy as well as immunofluorescence is very, very important. In some of the cases, it is important to correlate with the electron microscopic findings also. So, nephrotic and nephritic syndrome, let us have a look at the pathophysiology or what happens exactly in the glomerulus in these conditions. So, the basic mechanism is an increase in glomerular permeability. So, how does it differ? How is it that nephrotic syndrome and nephritic syndrome are two different syndromes if it is just an increased glomerular permeability? Now, the causes in both are different. So, in nephrotic syndrome what happens is there is podocyte injury. So, you remember that I said the visceral epithelial cells have food processes and these abut the glomerular basement membrane. So, in these conditions which lead to nephrotic syndrome, there is a loss of food process. So, in effect, the absorption area is reduced. So, this could be either due to podocyte injury or another cause is changed architecture, mainly deposition of matrix, hyalinosis or scarring, and this is usually non-inflammatory. No inflammation is associated in these conditions, whereas in nephritic syndrome there is an altered glomerular filtration rate. This could be a combination of various factors, or it could be individually one of these factors, that is proliferative changes of glomeruli, then glomerular basement membrane breaks, crescent formation or and inflammation. So, first we will have a look at nephrotic syndrome. Now, when do we say nephrotic syndrome? Is it just massive proteinuria? No, it is a combination of various factors, that is we should see massive proteinuria along with hypoalbuminemia, edema, lipiduria and hyperlipidemia. Now, these 5 should be there and it is an essential component for nephrotic syndrome. So, how much is this proteinuria? When do we say massive? We say massive when it is more than 3.5 grams per 24 hours. Now, there is a little bit of confusion regarding this, in the sense that some say that in children it is a little less, maybe more than 3 grams. Now, hypoalbuminemia we say when it is less than 3 grams per deciliter. Hyperlipidemia is of 2 types, hypercholesterolemia and hypertriglyceridemia, both are usually seen. Now, there can be other things also like hematuria, azotemia, hypertension and thrombotic tendencies. Thrombotic tendencies is often seen, whereas the others, hematuria, azotemia and hypertension, are not a predominant component of nephrotic syndrome. Now, in urine what do we see? We see a few cellular casts, oval fat bodies and massive protein. This is very important. The other aspects like RBCs and WBCs, then other casts etc. are usually not seen. So, this comprises the nephrotic urinary sediment. Causes for nephrotic syndrome can be both primary and secondary. Amongst the primary causes we have the most important ones like membranous nephropathy, minimal change disease. Membranous nephropathy usually seen in adults, minimal change disease in children. FSGS is or focal segmental glomerulosclerosis is another important cause of nephrotic syndrome seen in adults. Then membranoproliferative glomerulonephritis and others like, for example, IgA nephropathy can cause nephrotic syndrome. Then secondary causes, most important is diabetes mellitus. Then second one is amyloidosis, then systemic lupus erythematosus, various drugs, especially NSAIDs, then infections, malignancies as well as miscellaneous causes. We move on to the next syndrome, that is nephritic syndrome. So, in nephritic syndrome it is an acute phenomenon, and in that we get hematuria, edema, azotemia, hypertension, mild proteinuria and oliguria. This mild proteinuria can go up to 3 grams per 24 hours, but it is usually less than that, never beyond that. When it goes beyond that, we have to think whether the patient has a nephrotic kind of syndrome. So, most common example for this is post-streptococcal glomerulonephritis. So, remember the predominant component of acute nephritic syndrome is hematuria, azotemia, hypertension and oliguria. So, what do we see in the urine? We see a lot of RBC casts, then dysmorphic RBCs. Now, why are they dysmorphic? What do we mean by dysmorphic? Dysmorphic means it is irregular, the RBC is kind of crenated, and this because the RBCs, remember this is a glomerular condition. So, the RBCs are going through the glomerular basement membrane and coming out. So, therefore, it will be dysmorphic. Then you get WBCs and mild protein. Remember, it is an inflammatory process. So, that is why you get WBCs also. So, these together are known as nephritic urinary sediment. Now, let us have a look at the different causes of these nephritic syndrome. So, the primary ones, the most important is post-infectious glomerulonephritis, which could be either streptococcal or staphylococcal. Staphylococcal will also show IgA, but it will not be dominant. Then IgA nephropathy, then rapidly progressive glomerulonephritis types 1, 2 and 3, membranoproliferative glomerulonephritis especially type 1 and C3 glomerulopathies. Secondary are usually SLE, vasculitis, even in hypertension sometimes you can get. Next we move on to the next syndrome, that is the rapidly progressive glomerulonephritis. Now as the name suggests, it is rapidly progressive. So from nephritic syndrome, it progresses within hours to days to acute renal failure, also called as acute kidney injury, and the most important cause is crescentive glomerulonephritis. So there is a rapid decline in glomerular filtration rate in these cases. So this shows proteinuria, hematuria, oliguria, which progresses rapidly from nephritic syndrome within hours to days to acute kidney injury. This is rapidly progressive glomerulonephritis, that is acute kidney injury developing from nephritic syndrome very fast because of an abnormal or rapid reduction in glomerular filtration rate. Next we move on to acute kidney injury. So what happens in acute kidney injury? There is a rapid decline of glomerular filtration rate along with fluid electrolyte imbalance, and because the glomeruli are not functioning properly and the tubules are also affected, retained metabolic waste products will be there, and clinical presentation is as oliguria to anuria. It is usually reversible, and laboratory data you get recent onset azotemia. Okay, now before I proceed, let us find out what exactly this oliguria and anuria mean. So oliguria is when the volume of urine reduces beyond 500 ml according to some researchers, and 400 ml per day according to some researchers, and anuria is actually it means no urine production, but it has been defined as anything which is less than 100 to 150 ml per day. And remember that the acute kidney injury is reversible. So what are the causes for this? These could be glomerular, tubular, interstitial, vascular. Basically any compartment can be affected in acute kidney injury, or any compartment may be responsible for this. The most important of all these is acute tubular necrosis, also known as acute tubular injury. Next we move on to the end result of everything, that is chronic kidney disease. So when do we say chronic kidney disease? This is when azotemia has progressed and with all the biochemical manifestations as well as your endocrine abnormalities, etc. So because of that the patient is symptomatic and it has affected almost many organ systems in the body, that is uremia. So azotemia progressing to uremia is when we call chronic kidney disease, and this is defined as a glomerular filtration rate which has reduced to less than 60 ml per minute per 1.73 meter square for 3 months and or persistent albuminuria. Clinically it starts usually as a mild phenomenon, and it progresses to the severe chronic kidney disease, and usually it is very silent and asymptomatic. So by the time the patient presents, he may be in the end stage renal disease, which is nothing but a GFR which is markedly reduced, and it is less than 5% normal, and it is the terminal stage of uremia. So in severe cases there is prolonged uremia, and this is seen in end stage renal disease. Now remember that it is a final stage of all chronic renal parenchymal disease, irrespective of which compartment it has started. So what are the systemic manifestations of CKD or chronic kidney disease? You get fluid and electrolyte disturbances, calcium phosphate and bone manifestations, then hematological changes, then manifestations secondary to involvement of the gastrointestinal system, neuromuscular, then cardiopulmonary system, as well as dermatological manifestations. So let us have a look at exactly what happens in all these conditions. So you have dehydration, edema, hyperkalemia, metabolic acidosis. Then in calcium phosphate and bone abnormalities you have hyperphosphatemia, hypocalcemia, secondary hyperparathyroidism and renal osteodystrophy. So these will give rise to the bone abnormality seen in these conditions. Hematological abnormalities include anemia, bleeding diathesis. Cardiopulmonary manifestations are hypertension and congestive cardiac failure, cardiomyopathy, pulmonary edema, as well as uremic pericarditis. Gastrointestinal manifestations, patient may have nausea and vomiting, or esophagitis, gastritis, colitis or bleeding. Neuromuscular manifestations include myopathy, peripheral neuropathy as well as encephalopathy. Dermatologically, usually pruritus uveitis and dermatitis are common. Sometimes just a sallow color may be there. So, next we move on to the renal tubular defects. So, in this condition, that is whenever there are renal tubular defects, this could be just tubular structure or tubular functional abnormality. Now, tubular structure defects are seen in nephronophthisis, whereas tubular functions are abnormal in either inherited or acquired conditions. Inherited ones including cystinuria, renal tubular acidosis, whereas acquired conditions include lead nephropathy. So, all these present as polyuria, nocturia and electrolyte imbalance, that is especially metabolic acidosis. So, other renal disorders besides all these conditions that we have seen include urinary tract obstruction, maybe due to malignancies, etc. Then urinary tract infection, this presents as bacteriuria and pyuria. Now, the infections could be involving the kidney where it is pyelonephritis, or the bladder where it is cystitis. Then you can have tubulointerstitial nephritis, which could be either acute or chronic, nephrolithiasis, which presents as renal colic, which is spasmodic, and hematuria, which is painless. Tumors will present as painless hematuria. So, with this we come to the conclusion of this session. To summarize, remember that all the clinical manifestations of renal disorders are because of involvement of either one of these 4 compartments or all of these, which include glomerular or tubulointerstitial or vascular compartments. Then in glomerular, it is mainly an abnormal filtration which may be responsible, or a glomerular inflammation, and the syndromes that we see are 6 of them. The most important ones is nephrotic and nephritic syndrome. The remaining are asymptomatic proteinuria, hematuria, rapidly progressive glomerulonephritis, acute kidney injury and chronic kidney disease. Besides these syndromes, there are other causes too, which we learned today, that is renal tubular defects, urinary tract obstruction as well as tumors, and with that we conclude this session. Thank you so much for an attentive hearing. Thank you.